Hello everyone and welcome to our module on Wolff-Parkinson-White. The Wolff-Parkinson-White syndrome is a cardiac electrical disorder, and the cause of this disorder is what's known as an accessory atrioventricular pathway. This is a pathway in the heart that conducts impulses from the atria to the ventricle bypassing the AV node. It's sometimes referred to as a bundle of Kent. Normally the only way electrical impulses in the heart can travel from the atria to the ventricles is through the AV node, but in people with WPW there's an accessory pathway that also allows impulses to get to the ventricles. When impulses travel over this accessory pathway, it causes a phenomenon known as pre-excitation. This is where the ventricles depolarize before the AV nodal impulses reach the ventricles and cause normal depolarization. And the consequence of this pre-excitation and this accessory pathway is that these patients can develop arrhythmias, and we'll talk more about this in a minute. In many cases, the diagnosis of WPW is made by looking at the surface ECG, and the two classic findings in WPW are the presence of a delta wave and a short PR interval. Let's start by looking at the normal ECG on the bottom of the screen. Note that the QRS complex begins as a line going straight up and then coming rapidly back down. The ECG on the top is from a patient who has WPW, and you note that before the QRS complex goes straight up, there is this line at an angle here. That's called a delta wave, and that's caused by the accessory pathway. There is early or pre-excitation of the ventricles, and this causes some ventricular depolarization before the normal QRS interval begins from depolarization from the AV node. So the presence of a delta wave is one of the hallmarks of WPW on the ECG. In addition, because of the delta wave, the PR interval is very short. So you can see we have a P wave right here, and then almost as soon as the P wave ends, we have the beginning of the delta wave in the QRS complex. In contrast, on the bottom of the screen, in the normal ECG, there's a short flat portion between the end of the P wave and the start of the QRS. That is what is seen on a normal ECG. In WPW, there's a short PR interval. So the presence of a delta wave and a short PR interval are the classic findings in WPW. And here's a 12-lead ECG showing you the presence of the delta wave. You can see it right here in lead 1. You can also see it easily here in lead 2. If you look at lead 3, you can see it's downward going, but it's still there. You can also see the delta wave here in V3. So you can find these delta waves in all the different leads. Sometimes the delta wave goes up or down depending on which lead you're looking at. So to understand the consequences of an accessory pathway, let's review normal electrical conduction through the heart. So normally electrical activity begins in the SA node, and the only way that electrical activity can travel to the ventricles is by going through the AV node and then into the bundle branches and the His-Purkinje system. In patients with WPW, there is a bypass tract. It's some other portion of the heart that also will conduct impulses. When this is present, two things can happen. One is that impulses can normally go down the AV node in the bundle branches and then go up the accessory pathway and into the atria and create a loop. This will create an arrhythmia. These accessory pathways usually can conduct electricity both ways. They can conduct electricity from the atria to the ventricles and also from the ventricles back to the atria. The other problem that can happen with an accessory pathway, for example, if there was one right here, is that electrical activity can go from the atria down into the ventricles and then come up through the AV node. This can also create a circuit which will then cause a tachycardia. The type of tachycardia that occurs in WPW is called AVRT, or AV reentrant tachycardia, and don't confuse this with AV nodal reentrant tachycardia or AVNRT, which is a different arrhythmia. So in AVRT, there's a circuit that is created by electrical activity going through the AV node and through an accessory pathway. There are two types of AVRT. Orthodromic AVRT is AVRT that goes normally down the AV node and then comes up over the bypass tract. This creates a narrow, complex tachycardia like shown in this picture. The other type of AVRT is called antidromic. This type of tachycardia occurs when electrical activity goes down the bypass tract and up the AV node. This creates a wide complex tachycardia because the ventricles are not being depolarized normally through the bundle branches and Purkinje fibers. They are being depolarized abnormally through conduction over the accessory pathway. So what are the consequences for patients of having an accessory pathway? Well, first of all, you should know that most patients are entirely asymptomatic. The EKG shows a delta wave, but they have no symptoms whatsoever. These patients are said to have the WPW pattern on their ECG. Some patients will develop tachycardias like we just talked about, and these patients will develop palpitations. And when patients have the WPW pattern on their ECG plus palpitations or another symptom, we say that they have the WPW syndrome. And as I told you on the last slide, the arrhythmia that they get is AVRT, either anti or orthodromic. Now, rarely bypass tracts can lead to syncope or sudden death, but this is uncommon, and the treatment is a surgical procedure where the accessory pathway is ablated so that it no longer conducts electricity. When atrial fibrillation occurs in patients with WPW and a bypass tract, this is a very special clinical situation that can potentially be life-threatening. In the video on atrial fibrillation and flutter, I talk about how atrial depolarization in atrial fibrillation occurs very rapidly at a rate of 300 to 500 times per minute. Now, the AV node cannot conduct impulses that quickly. The AV node only conducts at a slower rate of something less than 200 beats per minute. Therefore, the ventricular rate in AFib is never 300 to 500 times per minute. It's something much slower than this, and that's because of the AV node. However, in patients with WPW, in some situations, the impulses can conduct very rapidly over the bypass tract. This can potentially lead to a very fast heart rate, so fast that the ventricle cannot fill and the cardiac output drops, and when this happens, the patient can lose consciousness and even die. So because of this reason, because the bypass tracts can conduct so rapidly, AFib is potentially life-threatening in WPW. And shown on the screen here is an ECG tracing from a patient with WPW and atrial fibrillation. Note that the QRS complexes are occurring at an irregular rate. So these two are close together, for example. These two are further apart. This is the typical irregular pattern of atrial fibrillation. However, normally atrial fibrillation occurs with a narrow or normal QRS complex. In this case, the QRS complexes are prolonged or widened. And the reason they're widened is because impulses are going over the bypass tract and conducting via the bypass tract to the ventricles. That is creating this wide complex, irregular tachycardic rate. And anytime you see a wide complex irregular tachycardic rate, you should be very concerned that you may be looking at a case of atrial fibrillation in WPW. When you have atrial fibrillation in WPW, if you slow conduction over the AV node, this is potentially dangerous and even life-threatening. The reason is because when less impulses go through the AV node, more can go over the bypass tract. Remember what I said in the last slide, some bypass tracts can conduct very rapidly. So if you allow the bypass tract to conduct as rapidly as it can by blocking the AV node, you can potentially cause a life-threatening complication for the patient. To make this more clear, imagine we have the ventricles, and the ventricles can be depolarized either through the AV node or through the bypass tract. Whenever the AV node conducts an impulse to the ventricle depolarizes, and that makes it refractory for a period of time. And during that time, the bypass tract cannot send any impulses to the ventricle. So basically, the AV node is somewhat protecting the ventricles from rapid impulses from the bypass tract by depolarizing it from time to time. If you slow conduction in the AV node, that will allow more impulses to reach the ventricles from the bypass tract, and that can raise the heart rate and be life-threatening. What this means is that the usual medications that are used in atrial fibrillation are contraindicated in WPW. So in patients who present to the emergency room with rapid atrial fibrillation, they are often administered beta blockers, calcium channel blockers, or sometimes digoxin. They're usually not administered adenosine, but adenosine also slows conduction in the AV node. And you can't use any of these drugs in WPW because they will drive more impulses through the bypass tract. They will drive less impulses through the AV node, and this can potentially be life-threatening. So the acute treatment for patients who have AFib and WPW with a rapid heart rate is ideally an electrical cardioversion, or sometimes antiarrhythmic drugs are used. Ibutilide and procainamide are both sometimes used because they slow conduction in the bypass tract, not just in the AV node. And in terms of step one, what's shown in this slide is the main thing you want to know about WPW. They want you to understand that slowing conduction in the AV node is potentially life-threatening. And that concludes our video on WPW.